part of the session, which is probably moving on to sort of the congenital side of things. So I was going to talk a little bit about antenatal sort of service and the place of delivery, and then Lawrence later on is going to go to more details about the place of delivery guideline that she signed off at the board last week. And then following on, Caroline's going to do a presentation about transposition. We've got Joe to talk a little bit about transfer of the cardiac patient. And then somebody asked at the last session if we could just talk a little bit about which patients require RSV prophylaxis. So Emma, one of our cardiac CNSs, is going to talk about that. So hopefully then when we'll get back to the main session at 4 o'clock. So I'm just going to tell you a little bit about, before they get to you on the neonatal unit, a little bit about the fetal service, so that you can sort of have a bit of an understanding of which patients, which babies should be delivered in the specialist centre, what the advantages and disadvantages of tertiary and local delivery, and where to get sort of support and information. So the fetal cardiology services were based now at the Fetal Medicine department at the Clarendon wing at the LGI. Previously were sat in the cardiac unit, but they realised how important it is to work very closely with the fetal medicine staff as well. So they moved down a few years ago. And it's run by two consultant cardiologists, Dr. Barwick and Dr. Brown. So part of their sort of week is diagnosing antenatally, and then the other part of the week is working sort of within paediatric cardiology as well. And then we have some experienced sonographers who again do sort of purely congenital sonography, and then they have specialised in fetal screening. And then we have 3 specialist nurses. So Marie, there in purple, she is the lead for the fetal service, and then two other sort of nurse specialists support that clinic as well. So there's quite a bit more information on the Leeds Congenital Hearts if people are interested in that. But basically what happens is referrals are sent from all the other network hospitals via the screening coordinators, and then they're triaged, and there'll be a reason why they've got being referred. So it might be family history, it might be the fact that they actually couldn't see part of the heart, or there has been an obstetric sonographer who has actually thought, yes, this probably looks like a query coarctation. So depending on that, then they are then fitted into a clinic which runs Monday to Friday. And NHS England have said that patients' families should be seen within 3 days referral, but often we are seeing them before that as well. So 8 per 100 babies will be born with congenital heart disease, and approximately 60% of the babies with significant and congenital heart disease will be diagnosed antenatally, which is massively increased over the last few years, and that is because of increased screening, increased training and education, and really sort of like, I suppose, absolutely sort of doing lots of education with the obstetric sonographers, which we've been doing over the last few years. So they're generally seen at about 18 to 20 weeks after they've had their anomaly scan, and parents are counselled then following a diagnosis by the cardiologist and the nurse specialists. They're then reviewed again at about 28 to 30 weeks if they've continued the pregnancy, because obviously you will only see the ones that have continued with pregnancy, and there are a number of ladies or families that choose to terminate depending on their sort of diagnosis. Once they've been seen and had that diagnosis, then the nurse specialists update the local midwives, the screening coordinators, and make sure they've got condition-specific information to help with that decision making. And again, what we've done quite a lot over the last sort of few years, 3 or 4 years, maybe a little bit longer now, is we've developed quite close links with the hospices. So we've got 4 hospices in our network. and the nurse specialists will make referrals if the families would like to do that, to help with support if they have a complex condition, and they may decide to go for comfort care when the baby's born. They may decide to go for treatment, but palliative treatment, and these are for the very complex ones, that the hospices, if they're involved even before the baby's born, that helps with that relationship and parallel planning, which is a very good model. So as we say, it's really important that we've had close links with the fetal medicine department, and at 28 weeks appointment, a decision is made as to where they need to deliver the baby, and that depends on this, obviously their condition. If they're delivering in Leeds, the obstetrician in Leeds is involved in the delivery plan, and they have a weekly Friday meeting to assist with that communication as well. And for those of you who work on the neonatal unit here in the LGI, I know you're probably very much involved in that sort of communication as well. So how to get access to clinical information. In Leeds we have PPM Plus, but I know that some of you in other hospitals have access to that, in Airedale and in Pinderfields. So there's lots of information on there that will be really useful to you. But we do send copy letters to the referring obstetrician and the screening midwives, which includes the delivery plan, and a copy is sent to the patient for their maternity notes. So, you know, if you don't get enough information, probably one of the first sort of places to look is the maternity notes. So obviously it's really important that we deliver the baby in the right place at the right time, and that's to optimise their outcome. And obviously that depends on the condition. So some conditions, which are generally those that are duct dependent, should deliver in the specialist centre, as in Leeds. And there's some advantages to that, because obviously we've got on-site paediatric cardiology on call. It eliminates the need for the postnatal transfer of the baby and the mother. Obviously then we get a definite postnatal echo, confirming the diagnosis. If intervention's required, then obviously it gives us time to organise that quickly, and hopefully reduces the potential for separation of mum and baby, but also reduces the need to transfer. But there are lots of advantages to be delivering locally, and there are lots of babies that are suitable and safe for delivering locally. And that's important, because obviously it's better for family support. It facilitates the sort of family links with the local paediatrician for ongoing support afterwards. It also builds up local expertise in managing congenital heart disease. And then we mentioned earlier just about those patients that choose to go for comfort care or link in with the hospice. And if they do go for comfort care, then that is so much better to be delivering locally. And I know we've had a few cases over the last sort of 12 to 18 months, one couple in Bradford, one in Doncaster, that was managed so well so that the family could then sort of be close to home. So what has been written now is a place of delivery guideline, which looks at a traffic light system. So there's some that were red that should be delivered in a cardiac centre. Some that are may be delivered locally, and then there's those with certain conditions that can be delivered locally. And Lawrence, I think, is going to go into those sort of a little bit more detail, but generally the red are those like transposition of the great arteries, who need some intervention, need some crossing to start with. The green are the AVSDs, the VSDs that hopefully can be nursed locally and discharged home and then seen in the cardiology clinics that will then likely need sort of intervention or surgery in the first few months of life. And then those in the amber, it really depends on the sort of the circumstances. but I think some of those will include those with palliative care. So if we feel that even though they are complex but won't need treatment straight away, they might be able to be delivered locally. So the protocol can be found on the network website, but the sort of thing that made me think about when we did this guideline is, yes, 60% are diagnosed antenatally, but then there's 40% that are not. And they're the ones that generally you will see in your local hospitals that you weren't expecting to come through your doors, and that is when you need more support. So I think it's really useful to sort of, I suppose, think about where you can get some help and where you can sort of understand a little bit, because you might not see a patient for 12 months and then they are delivered locally. And there's an expectation that you will have that skill set and knowledge, which is unfair, I think, at times. So, I think it's important for you to know where to get some information. So each neonatal unit has either a paediatrician with an expertise, a PEC. So you met, if you were on the meeting earlier, Matt Pye, who is a PEC, and he's at the Pinderfields, or a neonatologist with expertise such as Sam Wallace, Lawrence Mile here in Leeds. So it's important to find out who your PEC is, or your neonatologist, who you can go and get some sort of pick the brains, get to know what, and get them to do some teaching for you. I've tried over the last sort of couple of years to try and get a cardiac link nurse on each neonatal unit. So ask on your unit if you don't know who they are. In Leeds, they have a betas team. So there's a group of nurses, but on most neonatal units in the region, there should be at least one cardiac link nurse who, we're not saying they're the experts, but they are somebody to go to where they can help you to get advice and help. The cardiac nurse specialists are happy to be emailed or telephoned, and Ward 51 is where all the children go for their surgery. So again, the nurses are very experienced and happy to sort of give some help and advice. And I mentioned the betas team, and they have done a fabulous resource file that all of you should have on your unit, and it looks like this. So it's a file that's got about 40 pages with all the different conditions in there. So if you don't know where it is, if you can try and find it, that would be great. And if you haven't got one, just let me know. I've also got electronic versions, so if you do want a copy of it, I can email it to you. So if you want any local education sessions on your neonatal units, please get in touch. We're really happy to help with that. Keeps me in a job, and thank you for listening. Thank you.